To everyone. Welcome to the Climb India Journal Club, which is conducted as a part of an educational outreach activity, as a part of our Center for Advanced Research project looking at the impact of climate change and brain infections. So, in this journal club, we've been discussing varied topics starting from dengue vaccines, evidence, so on and so forth. So, in this journal club, we are going to discuss about the evidence-based management of cryptococcal meningitis, which is now we are seeing a rise. Previously, it was thought to be of a disease of HIV or immunocompromised, but of late, we are seeing quite a bit of disease among immunocompetent hosts, possibly due to higher degree of environmental exposure, and why this fungus is increasingly now reported as a cause of chronic meningitis as well as subacute meningitis spectrum. So today we have our distinguished panelists, Dr. Mahendra Thakre. Sir is an assistant professor at the Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences at Meghalaya. And it's been a very, they've been a very active Sentinel Center for our Climb India project. And they see a very unique spectrum of disorders as well, being in a unique climatic zone of highlands climate. So they do see a lot of vector-borne diseases in view of the high humidity and extremes of rainfalls. They see a very high burden of vector-borne as well as they see a lot of cryptococcal meningitis is what I understand. It's nice to have you here, sir, on board. And the moderator for today will be Dr. Selvakumar. Dr. Selvakumar is the assistant professor in the Department of Neurological Sciences at CMC Vellore. And he's quite very well versed in clinical neurology as well as neuroinfections. And in fact, Dr. Selvakumar had managed a couple of cryptococcal meningitis in the ward recently, so which puts him at the right time and place to discuss this journal club and the evidence as to why we are doing certain interventions which we are doing. So over to Dr. Mahendra Thakre for the presentation, and I request Dr. Selva to lead the session.
Thank you, ma'am. Already ma'am introduced the topic. Without delay, we will go to the topic proper. Over to you, sir.
Thank you. Thank you, ma'am. We'll start our session today. Today's topic is cryptococcal meningitis evidence-based management. Today we are going to review the landmark 3 trials and how the evidence has changed throughout the years. Before that, these are the 4 antifungal drugs in cryptococcal meningitis we have currently. First is amphotericin B, that is a deoxycholate. It binds to ergosterol in the fungal membrane, forming the transmembrane pores. It then leakage of potassium, magnesium, and other contents and leading to the cell death. It is mainly fungicidal, but it has an inherent problem that it has a nephrotoxicity, electrolyte loss, hypokalemia, hypomagnesia that we encounter during the practice. And there are also a lot of infusion-related reactions. So we have come up with a liposomal amphotericin B. It has the same action. It also binds to ergosterol to form the membrane pores, and being a liposomal delivery targets is targeted in infected tissue and spares the kidneys. It has also fungicidal and similar efficacy as a conventional amphotericin. Major advantage, he has lower nephrotoxicity and infusion-related reactions. And we have a unique drug that is flucytosine. It's acted by a cytosine permease and enters the fungus, and it converts into the 5-fluorouracil by the cytosine deaminase. 5-fluorouracil blocks the DNA synthesis and impairs the protein synthesis. Inherently, it is a fungistatic alone, but when we combine with the amphotericin B, it acts as fungicidal. And it has excellent CSF penetration and good early fungicidal activity. With amphotericin B, it gives the fastest fungal clearance and lowest mortality. Fluconazole is a well-known drug. It inhibits the 14 alpha demethylase, blocking the linosterol and ergosterol conversion. It decreases the ergosterol, disrupt the membrane, and has the fungal growth. It is fungistatis. Main advantage of it is oral agent. It has good bioavailability and good CSF penetration. Used for consolidation and maintenance therapy, and may supplement induction when the required. So these are the 4 drugs available currently. While treating the cryptococcal meningitis, we have 4 basic questions, 6 basic questions, in fact. Among all these 4 drugs, what is the optimal induction regimen? Which drug to combine, which has maximum benefit, which has lowest side effect, that we have to decide. Second question is, can amphotericin therapy be shortened? We know amphotericin is very good drug, fungicidal drug, but it has toxic effect. So can we reduce the amphotericin therapy duration? That is one question. Another is flucytosine is indispensable. If flucytosine is not available, what we can do? Then fourth question is, when should ART be initiated? Whether we have to initiate immediately or we have to wait for 4 to 6 weeks. What is the ideal time for initiation of ART? Fifth question is, does the management differ by the host? Now we know, okay, not only HIV patient, but other immunocompromised patient also present with the cryptococcal meningitis. So what do we in that scenario? Then, how the landmark trials has reshaped the international guideline. The first guidelines comes in the in Infectious Disease Society, which is in 2010. Then WHO 2022. Then global guideline comes in 2024. The what changed and why it changed, that we'll try to discuss. So pre 2010, the era of expert opinion. There are not much randomized trial, so we depend on the expert opinion. In 2010 IDSA guideline, there also, but guidelines for randomized trial they were there, but evidence were not sufficient. Then 2014 code trial came, 2018 ECTA trial came, and 2022 Ambition CM trial came. This has changed the giving the good evidence, and the guidelines has changed. Now latest guideline is 2024. What say IDSA 2010 guidelines? It says that the induction therapy amphotericin B is 14 days with flucytosine 100 milligram per kg for 14 days. Then comes the consolidation phase, that is fluconazole 400 milligram, and then maintenance phase is fluconazole 200 milligram up to 1 year, or based on the CD4 count. In that guideline says that the ART can be initiated within 2 to 10 weeks after the start of initial antifungal treatment. There are no clear-cut evidence of when to start the ART. Then comes the our first question, that is, when should antiretroviral therapy be started? This is one clinical scenario where we can see it is a 34-year-old male patient, ART Navy, HIV infected adult, newly diagnosed with cryptococcal meningitis. CD4 count is 28 cells per micromolar. Then he has completed 2 weeks of amphotericin B induction therapy and clinical condition improving. He remained profoundly immunosuppressed. So whether in this case when to start the ART? If you start early, we have some benefit, very early immune recovery. There will be rapid HIV viral suppression and reduced risk of other opportunity infection. But there is a risk of developing iris. So whether we start delay, it has potential benefits as low risk of streptococcal iris, less CNS inflammation, reduced intracranial pressure complications. So decide that time their code trial came, which answer this question, when to start the ART. So this is a code trial, that is cryptococcal optimal ART timing code trial. The trial published in 2014, New England Journal of Medicine. The trial is done by the David and the colleagues. So what is a code trial? The study design was multi-center randomized open-label parallel group strategy trial. Study sites is mainly in the African country, in the Uganda, then in the Cape Town, South Africa. The study population is 177 ART Navy adults with confirmed HIV-associated cryptococcal meningitis. Intervention was early ART initiations 1 to 2 weeks after the diagnosis, and comparator was delayed ART after 5 weeks of diagnosis. The antifungal therapy was used amphotericin B plus fluconazole for 14 days, followed by the fluconazole consolidation in both groups. The primary outcome was all-cause mortality at 26 weeks. The secondary outcome was mortality at 46 weeks and cryptococcal iris, fungal clearance, relapse adverse event. The follow-up was up to 46 weeks. So what was the PICO framework in this trial? The population was ART navy adults more than 18 years of age, confirmed HIV-associated cryptococcal meningitis, receives and standard amphotericin B induction therapy. Intervention group was earlier ART initiation, started 1 to 2 weeks after cryptococcal meningitis diagnosis. Median initiation was 9 days. Comparator, defer ART initiation started 5 weeks after the cryptococcal meningitis diagnosis, and median initiation was 36 days. This was a comparator group. What was the outcome? At all cause, primary outcomes was all cause mortality at 26 weeks. Secondary outcome was mortality at 46 weeks, and cryptococcal iris, early fungicidal activity, relapse of cryptococcosis, and grade 3 to 5 adverse event. So this is the PICO framework for this trial. What was the inclusion criteria? Age is 18 years of age, HIV positive, ART navy patient they have included, and cryptococcal meningitis confirmed by the CSF culture and cryptococcal antigen, and they have received the induction therapy. What was the exclusion criteria? Those who are unable to complete the follow-up where the LP is contraindicated or refuse, or other concurrent CNS infection or previous cryptococcosis infection was there. Pregnancy and breastfeeding patients were included. Severe comorbid conditions were included. The screening, the adult with suspected meningitis were screened at the admission and received the counseling regarding HIV, cryptococcosis, ART, and study participation. The study period was between November 2010 to April 2011. So this is a heart of the trial design. They intended to include 500 patients, but when they found that early ART group has a severe side effects and mortality, the trial has shortened. The eligible participants were 177. The induction therapy before randomization, they give the amphotericin B plus fluconazole. Then randomization done with 1:1 ratio, stratified by the study site and Glasgow Coma scale less than 14 and normal GCS. The early ART arm included 88 patients and deferred ART included 89 patients. The standard follow was through 46 weeks, and primary endpoint was all-cause mortality at 26 weeks. So this is multicenter, open label, and both receive common antifungal regimen, and it was intention to treat analysis. The randomization done with computer-generated permutative block randomization and 1:1 allocation, early ART and deferred ART. The allocation was stratified by the study site and mental status enrollment based on the GCS score. So these are the baseline parameter. The key points in the baseline parameter, demographic characteristics were similar between the two groups. Severity of illnesses, CSF finding, cryptococcal antigen titer, HIV disease markers were well balanced. No statistical significant difference in the baseline variables. The summary, two study arms were well matched and baseline, ensuring compatibility for outcome assessment and minimizing the bias. The randomization was done well. These are the main result. So here A, we see the Kaplan-Meier survival curve. The light green is a deferred ART and dark green is earlier ART. This is cumulative probability of survival. 1 indicates 100% survivability, 0 means. So here we see in the graph, after the 1 month of the randomization, the earlier ART has the lowest survival rate, while the compared to defer ART. After the 1 month, the both graph remain parallel. The p-value was 0.03. So it says that the earlier ART initiation was associated with the risk of death within 26 weeks. That was 15% point higher than the associated ART initiation at 5 weeks after diagnosis. P-value was very significant. The next two graph is very important to understanding the result. What they have stratified the result according to the WBC count, CSF WBC counts. When they see the more than 5 cells in the CSF and they assess where the early ART and defer ART, what happens to their survival rate. When there's a more than 5 cells, the early ART and defer ART have similar mortality or risk of the death. While when the cells are less than 5 cells, the defer ART is performed better. Group is performed better. So what it suggests that if more than 5 cells, that means there are more inflammation is there. And less than 5 cells means there is a less inflammation. Patient is more immunosuppressed. Their CD4 count is less. Viral fungal load is high. In that case, differing starting earlier ART has a poor outcome. So this is the stratified forest graph for the early and late deferred ART. The CSF white cell count at transmission was only significant effect modifier. When CSF WBC count is less than 5 cells, the early ART was should with the significant higher mortality. When the CSF WBC count is more than 5 cells, the no survival difference between the early and deferred ART. The no subgroup demonstrated a survival benefit with the earlier ART initiation. The trend toward the higher mortality with early ART was also observed with the CD4 count less than 50 and altered mental status, which was not statistically significant. So deferred ART, that is at the 5 weeks, was constantly safer, particularly in the patient with the minimal CSF inflammation, that is CSF WBC cells less than 5 cells. The secondary outcome, there was no significant difference between the cryptococcal iris between the early and deferred ART. The fungal clearance was comparable with similar CSF culture positivity at day 14, indicating the early ART did not enhance the antifungal efficacy. The cryptococcal relapse was numerically lower in the early ART, that is 2% versus 9%, but the difference did not match statistically significance. The grade 3 and 5 and grade 4-5 adverse events were similar between the two groups, suggesting no increase in the treatment-related toxicity with either strategy. The survival benefit of the deferred ART was not explained by the difference in the iris, fungal clearance, and toxicity of virologic response. These outcomes were largely similar between the groups. So they assessed the cause of death, that is the key findings. The cryptococcal meningitis related death were higher in the early ART, that is 19 versus 10 death. During the first 2 to 5 weeks, that is early in the course, within 1 month, 10 cryptococcal meningitis related death occurred in the early ART group versus 3 in the deferred ART group. The non-cryptococcal cause of deaths were bacterial sepsis, tuberculosis, pulmonary embolism, drug toxicity, iris were similar in the between group. The many patients who died had improved fungal clearance and controlled intracranial pressure. The investigator concluded that the excess mortality was likely related to the exaggerated CNS inflammatory response after the early ART, because maximum death occur in the early phase of the illness. Early ART increased the death primarily from the cryptococcal meningitis related to neurological complications rather than from the drug toxicity and opportunistic infections and or confirmed iris. So, what is the clinical takeaway from the core trial? The antifungal induction start standard induction immediately at the diagnosis, delay the ART at least 4 to 5 6. In the core trial, median was 36 days. Initiate ART after the 4 to 6 weeks once the patient is clinically stable and meningitis treatment is established. The key message from this core trial, the differing ART at 26 weeks cuts the mortality. Excess ART early death clustered at 2 to 5 weeks, that is early phase of illness. The highest risks with early ART were low CSF white cell count. Recognized iris rate were similar in both groups. All other outcomes were similar. So optimal strategy is that start antifungal induction immediately, delay ART, initiate ART after 4 to 6 weeks, and balancing the early infection control with reduced immune reconstitution risk and improve survival. We'll assess this trial by the CAST questionnaire, which is for the randomized control trial. In this CAST questionnaire, they have divided the sections, section A, B, C, and D. Section A is for the mainly validity, section B is for the methodology, section C is for the result, section D is applicability of the trial. The first section A, the CAST questions is did the study address the clearly formative research? Yes, because he has clearly defined the PICO principle is there, population, intervention, controller, and outcome. Was the assignment participants to the intervention randomized? Yes, it is computer generated permitted block randomization stratified by the study site and Glasgow Coma scale. Where the participant who entered in the study accounted for its conclusion. It is intention to treat analysis was performed. Only one participant withdrew after the randomization. No loss to follow up, but the trial was stopped early after 177. That is, planned participant was 500 participants because of excess mortality in the early ART group. So core trial demonstrated good internal validity overall. What about the methodology? The blinding. It is open label trial. The no blinding was no, neither participants were blinded and not the treating clinicians were blinded. But the outcome was mortality outcome. It is an independent external adjudication committee blinded the ART allocation, reviewed the iris, events and cause of death, reducing the detection bias. Whether the study group similar at the start of randomized controlled trial? Yes, baseline demographic and clinical analysis were similar in the both group. Apart from the experimental intervention, did the study groups receive the same level of care? Yes, both the group reveal same level of the treatment like induction therapy, therapeutic lumbar puncture, supportive care, and identical ART regimen. Only the timing of ART was differed. So this says that the core trial is demonstrates good internal validity overall. Limitations include open label device design, early stopping, and modest loss to follow up. Regarding the result, where the effects and intervention reported comparatively, yes, sample size calculation was reported. Primary, secondary outcome, hazard ratio, confidence intervals, Kaplan-Meier, survival curve, subgroup analysis, adverse event, fungal clearance, iris, all has comparatively presented. Was the precision of the estimates of the intervention treatment effect reported? Partially, because hazard ratio were presented with 95% confidence interval, primary outcome, early mortality, but it is hampered by the because early stoppage of a trial. The precision subgroup analysis was lower because early trial termination. Do the benefits of the experimental intervention outweigh the harm and cost? Partially, because early ART increased the mortality, that is 45% versus 30%. The absolute increase is 15% point. Although cost-effective analysis was not evaluated, the clinical harm outweighed any theoretical benefit of earlier immune recovery. It is not known. Deferred ART demonstrated the superior benefit risk profile. So important clinical relevant results showing harm with early ART. The limited precision because of early stopping of study, risk of bias because open label, iris ascertainment, and the antifungal regimen temporary full confidence in the exact magnitude and generalizability. Then the applicability can result applied to your local population. The study population was ART naive with HIV, confirmed cryptococcal meningitis in the South Africa and Uganda. Similar to many patients seen in the resource limited setting with advanced HIV disease, may not fully apply to setting with earlier HIV diagnosis, higher CD4 count, or different standard of supportive care. Would the experimental intervention provide greater value to the people in your care than the existing intervention? It is also partially because conducted in tertiary hospital in sub-Saharan Africa, the real world practice is similar, reflect the real world practice is similar setting. The antifungal regimen did not include the flu cytosins, which was unavailable during that study sites, which limits the direct capability setting where flu cytosins is standard. The difference in the healthcare resources and monitoring capacity may influence the outcome. The finding applied to many patients with cryptococcal meningitis in resource-limited setting with advanced HIV disease. The key considerations include the difference antifungal regimen, healthcare resources, and the patient characteristics. So what are the strengths of the core trial? It is multi-center trial, clinically meaningful mortality endpoints, excellent follow-up, and the blinded endpoint justification is that death and iris events were adjusted by the independent committee blinded to the ART timing and reduced the detection time. These are the strength of the core trial. What are the limitation? Open label design, early terminations because of excess mortality in the early ART arm. No inflocytosine induction regimen, that is key limitations. Possible iris bias is there because iris definition required prior clinical improvement, risking under recognition of the early iris in the earlier ART arm. The limited applicability to the modern tenofovir based ART. They have not used the tenofovir in the ART regimens. So that can be a limitation for the code trial. Though the code trial provides us good evidence that deferred ART is an ideal choice in the cryptococcal meningitis. Now we'll see the what best induction regimen. The could shorter induction regimen work. So, under IDSA 2010 guidelines, amphotericin was 14 days, flucytosine was 100 mg for 14 days, then consolidation was fluconazole, maintenance was fluconazole. So, why was the clinical trial needed to get the better induction regimen? Because we know that amphotericin and flucytosine was effective, but we did not know that time that their 14 days duration was necessary because we know the amphotericin B causes toxicity. The amphotericin B rapidly sterilized CSF. Could the shorter regimen work? That we don't know because it has impact on the hospital stay. Amphotericin caused nephrotoxicity and anemia. Could because the liposomal formulation we use, it can improve the outcome. Then flucytosine improve the fungal clearance. Was it essential to all setting where the flucytosine is not available? So what we can do achieving the best result in the cryptococcal meningitis. So these are the questions. That's why trial was needed. The extra trial give the answer to all these questions. So this is the first landmark study that fundamentally challenged the conventional induction therapy. ACTA is Advancing Cryptococcal Meningitis Treatment for Africa. This published in 2018 in the New England Journal of Medicine. Mowley and colleague had done this trial. This is one of the landmark trial in the cryptococcal meningitis. See, this is also phase 3 multi-center open label randomized non-inferiority trial. HIV population was HIV associated cryptococcal meningitis. It is conducted in the 9 centers across the 4 African countries. Sample size 421 randomized and 678 including the intention to treat analysis. The primary endpoint was 2-week all-cause mortality. Why they choose the primary endpoint is 2 weeks? Because what mortality occurs within the 2 weeks, it is attributed to cryptococcal meningitis more. And follow-up was 10 weeks. So these are the trial centers. One is Malawi. There are 3 Malawi. That is 3 centers were there. Zambia 2 centers were there. Tanzania 2 centers were there, and Cameroon 2 centers were there. Total they have assessed 1,243. Total assessed the patient for the eligibility. 502 excluded, and 720 finally enrolled. The enrollment period between the January 2013 to November 2016. So this is one of the largest trial of the cryptococcal meningitis. PICO framework, the population was adults, HIV positive, first episode of cryptococcal meningitis, CSF positive by the India in cryptococcal antigen or both. The intervention, they include 3 induction regimen. One is oral fluconazole plus flucytosine. This is a totally oral regimen. Second one was 1 week amphotericin B. Third regimen was 2 week amphotericin B. The 1 week amphotericin B regimen combined with the fluconazole or flucytosine. Again, 2 week amphotericin B regimen was included plus flucytosine or fluconazole. So there were total 5 treatment group. One is oral fluconazole with 5-fluorouracil. One was 1 week amphotericin plus fluconazole. 1 week, third was 1 week amphotericin plus flucytosine. Fourth was 2 week amphotericin with fluconazole, and fifth one 2 week amphotericin plus flucytosine. And standard comparator was 2 weeks amphotericin regimen. Outcome was primary 2 weeks mortality. Secondary outcome was 10 weeks mortality, fungal clearance toxicity. Why they choose the primary outcome at 2 weeks? Because it is most whatever mortality occurred in the 2 weeks, it is based attributed to the cryptococcal meningitis. Exclusion criteria. The exclusion criteria was prior antifungal therapy, pregnancy, lactation, concomitant medications that is contraindicated, and previous hypersensitivity reaction to the study drugs. When they include the study participant after randomization, when they found that there are ALT raised more than 5 times upper limit, neutrophil count less than 500, platelet count less than 50,000, and persistent creatinine value more than 2.5 milligram deciliter after rehydration. This patient also excluded. This is called late exclusion criteria that adopted in the study. Then during the study, when they have included almost 4% enrollment, they noticed that when they initially excluded the patient with prior ART exposure, the many patients receiving a prior ART exposure become they coming more. So they included that patients after the 4% of enrollment. The large number of patients were presented with cryptococcal meningitis while taking on ART. So they don't wanted to lose this patient. So this is all frame study design for the ACTA trial. There are 720 HIV-associated cryptococcal meningitis patients randomized into three groups. One is oral regimen, second is 1 week amphotericin B regimen, and 2 week amphotericin B regimen. The oral regimen consisted of fluconazole plus flucytosine. 1 week regimen consisted with amphotericin B plus flucytosine, 113 patients, amphotericin B with fluconazole, 111 patients. In 2 week amphotericin B group, 150 amphotericin B with flucytosine and 140 amphotericin B with fluconazole. So they compare oral regimen, 7 days amphotericin B regimen, and 14 days standard 2 weeks amphotericin B regimen. Then follow-up was 10 weeks, and the primary outcome assessed at 2 week all-cause mortality, and secondary outcome was 10 weeks all-cause mortality plus fungal clearance and toxicity and safety. The randomization also was well done. Computer-generated block randomization stratified by the site, and participants allocated to 3 treatment regimen, and allocation ratio, because there are 5 groups, so 2:1:1:1. The allocation concealment sequential sealed envelope. So the baseline characteristics
Sorry
of
to
the
interrupt you, sir. We 30 minutes cross, sir. We will, I think we hope that we will finish in 15 minutes, and then 15 minutes or 10 minutes we'll keep for discussion, sir, at the end.
Okay, sir. Okay, sir.
Okay, sir. Just to remind. Yes, sir. Thank you.
The baseline characteristic of study participant, they are well matched. These are the result. What they found that fluconazole plus flucytosine and amphotericin B 1 week regimen, amphotericin 2 week regimen, all have achieved the all-cause mortality similar. The Kaplan-Meier survival curves demonstrate that all short-term treatment regimens were non-inferior to the conventional 2 week amphotericin regimen. More importantly, mortality did not increase despite reducing the amphotericin exposure, and fungal clearance also remained comparable between the regimen. One more thing they assess that they compare amphotericin B plus fluconazole versus amphotericin B plus flucytosine. Here they found that there is a significant difference in the all-cause mortality. They noticed that the 1 week amphotericin B with flucytosine has the lowest mortality, and they have rapid fungicidal activity and shortened amphotericin exposure, less nephrocytic, less anemia, and flucytosine is a superior partner drug when we compare to the fluconazole. These are the additional finding from this study. The safety outcomes, they have noticed that the standard 2 weeks amphotericin have the oral side effects were more compared to the 1 week amphotericin B and the oral regimen. When the cast validity is checked, the PICO principle was followed correctly. Then the randomization was very good. The follow-up was also very good. Very few patients lost to follow-up, very minimal. So this also was excellent. Again, it is open label, right? The blinding participant and were allocation. So there will be performance bias associated with the subjective outcome. But the outcome was mortality. So that can be adjusted. The similar groups were treatment in the both group. That outcome assessment was primary outcome and with this well defined. Results also were well precise. The oral regimen versus 2 week amphotericin 2 week amphotericin has the managed the non-inferiority criteria, that is less than 10% of margin. 1 week amphotericin B regimen also managed that no low non-inferiority margin, that is less than 10%. So mortality benefit is lower toxicity and short-term hospitality and pragmatic advantage of the short-term amphotericin B regimen. What was the applicability? Yes, first episode of HIV cryptococcal meningitis, resource limited settings, national WHO program where they are running, and conventional amphotericin B and affordable when there is a flucytosine is available. With caution, organ transplantation because they are excluded from the trial, immunocompetent hosts that were excluded from the trial, liposol amphotericin B was not assessed in this trial. Flu cytosis availability, if it is not available, that does not need the therapeutic drug monitoring. Then the evolving evidence bias, that is predict the single dose because after the trials are come for the single dose amphotericin B regimen. So these are the area where we cannot apply this result. These are the strength and limitation. We already discussed strength of limitation of ACTA. Strength is because it's large pragmatic multicenter RCT, robust randomization and concealment, excellent retention and rigorous analysis, hard clinically meaningful endpoints. And the limitations were open label and HIV population only they have assessed. They have not assessed the non-HIV population. Because they have followed only 10 weeks. What happened to this patient after the 10 weeks? Whether the long term they have achieved the same benefit, survival benefit or not. So this is done by the trial 1-year mortality outcome from the advancing cryptococcal meningitis statement for trial in the cryptococcal meningitis. It was published in 2020. It says that when they compare for the long durations, 1-year follow-up, the 27.5% 1 week amphotericin B has the lowest mortality rate. So it in long term also, when we shorten the regimen, also has the benefit. So can we achieve the same survival with a simpler and safer induction regimen? Because the ACTA trial did not assess the liposomal amphotericin B regimen. So this has assessed by the Ambition CM trial. This also is recently published in 2022 by the Jarvis colleague. This is also a landmark trial that has changed the guidelines. So Ambition CM trial is a phase 3 multicenter randomized open label control non-inferiority trial. It is done in the 5 African countries, 8 hospitals. Total study population was 814. They have used the single dose liposomal amphotericin B plus 14 days flucytosine plus fluconazole. And the comparator was WHO standard regimen, 7 days amphotericin B, flucytosine, followed by the 7 days fluconazole. The primary outcome was all-cause mortality at 10 weeks. So these are the Ambition trial where their study population was recruited. They have assessed almost 1,193 participants were assessed and 844 patients were randomized. This is a PICO framework. HIV positive status where study population, first episode of cryptococcal meningitis and positive index 10 cryptococcal antigen test with CSF was samples. The intervention was single high dose liposomal amphotericin B plus 14 days flucytosine plus 14 days fluconazole. Comparator was WHO recommended regimen amphotericin B deoxycholate with flucytosine 7 days followed by the fluconazole 7 days. The primary outcome was all-cause mortality at 10 weeks and non-mortality margin kept again 10% points. Secondary outcomes was mortality at 2, 4, and 16 weeks and early fungicidal activities and laboratory safety outcomes. This is a trial. 844 patients were eligible. Randomization was done as 1:1. The earlier experimental arm was 407 patient and WHO standard arm was 407. So single dose amphotericin B was given along with the flucytosine 100 milligram for 14 days with fluconazole 1,200 milligram for 14 days. And follow-up was up to 16 weeks. Primary endpoint assessed at the mortality at 10 weeks. The baseline characters were similar among the all group. So randomization has achieved excellent baseline comparability. This is the main result. The primary outcome at 10 weeks mortality, the 24.8% versus 28.7% mortality in favoring the liposomal amphotericin single dose. Absolute risk reduction was 3.9%, met the non-inferiority margin with a lower mortality rate. Adjusted analysis 5.7% lower the mortality with amphotericin B. The secondary outcomes, early fungicidal activity, excellent in the both groups. The mortality at 2, 4, and 16 weeks constitute the primary outcome. Iris were similar in the both group. Cryptococcal relapse with 0 in liposomal group, single dose group than the control. The hospital admissions at 10 up to 10 weeks identical in both, that is 17.4%. The lower cumulative mortality in with single dose liposomal amphotericin B throughout the follow-up. 10 weeks mortality also 24.8% versus 28.7%. The single dose liposomal amphotericin B was non-inferior to the standard regimen with consistent trend toward the lower mortality. The safety outcome, fewer grade 3-4 adverse event noticed in the single dose amphotericin group. The less severe anemia with fewer transfusion, lower nephrotoxicity, less hypokalemia. So single dose liposomal amphotericin B was substantially safer with the standard 7-day regimen. So why it was pharmacokinetic advantage that the liposomal formulation is higher tolerance, prolonged tissue residence, substantial CNS drug concentration, effective fungicidal activity. The clinical evidence that single IV infusion, less nephrocytosis, less anemia, reduced electrolyte disturbance, simplified monitoring, and shorter hospitalization. The single high dose amphotericin B achieved the prolonged fungicidal exposure while minimizing the toxicity. The CAST framework, this trial also was achieved the good internal validity when we use the CAST framework. Only with it is blinding was a problem because it is open label trial. But the primary outcome was mortality, so this can be minimized. The results also was robust. These are precise results, and though there was formal cost-effective analysis was not performed. Applicability, this trial was done on HIV positive patients where we can apply. First episode of critical meningitis, similar resource limited setting we can apply this trial results. Clinical value, it is single dose liposomal amphotericin B provides comparable efficacy, substantial lower toxicity, easier administration, reduced inpatient and resource utilization. Drug cost as availability remain implementation barrier. So these are the strengths for the ambition same trend. It is phase 3 randomized trial, pragmatic, multi-center, improve real-world applicability, objective primary endpoints, robust randomization, and consistent result across the unadjusted, adjusted, IT, and per protocol analysis. Strength of the internal validity of the trial. Limitation is open label designs. The conductor excluding the HIV positive populations, limited evidence in children, pregnant, and transplant recipient, high cost and limited availability of liposomal amphotericin B fluoxetine certain region where we cannot use this regimen. Even though with this limitation, the ambition CM trial was excellent trial, which provide the good evidence for the single dose amphotericin B regimen. So after this trial, the WHO has revised their preferred induction regimen to the single dose liposomal amphotericin B with fluoxetine and fluconazole. So that was the impact of this trial. Now, next topic question about the cryptococcal meningitis intracranial pressure ICP control. Why it is important? Because main mechanism of raised intracranial pressure in the cryptococcal meningitis is impaired CSF flow due to the obstruction of aragonite granulation and obstruction hydrocephalus due to the high fungal bud that shed the capsular polysaccharide accumulate at the aragonite granulation and meningeal lymphocyte roots. So this is CSF obstruction is the main cause of raised intracranial pressure. There is inflammation, but that not play major role in the cryptococcal meningitis. So these are the two trials that assess the therapeutic lumbar puncture. One is the trial by the Melissa, the effect of the therapeutic lumbar puncture on the acute mortality of the cryptococcal meningitis. And second, how many lumbar punctures is beneficial in case of critical meningitis. That is done by the Kingmu et al. That is therapeutic lumbar puncture is a human immunodeficiency virus associated with the cryptococcal meningitis. Should opening pressure direct the management? So this trial shows that the therapeutic lumbar puncture were associated with the 69% relative improvement in the survival through 11 days individual with the HIV-associated meningitis. The second trial also shows that when we do the patient do the no therapeutic lumbar puncture, there is a 33% mortality, where patients who underwent the one therapeutic lumbar puncture, mortality reduced to 22%. When patient do the more than two lumbar puncture, the mortality reduced to 19.5%. The more therapeutic lumbar puncture, better survival, more than two lumbar puncture in the first week of associated with the lowest 30-day mortality. So global guidelines says that the measure CSF opening pressure at the lumbar puncture, treat the symptomatic elevated pressure with the opening with the daily therapeutic lumbar punctures, remove the 20 to 30 ml CSF, achieve that the 50% of opening pressure is reduced or closing pressure should be less than 20. And perform the scheduled therapeutic punctures 48 to 72 hours on the day 7. If resistance raise ICP is there, then we can go for the lumbar drain, VPC, and ventriculostomy. Could we use the steroid to prevent the iris? So this is the CryptoDX trial, which was published in 2016. It says that the adjunctive dexamethasone provided no survival benefit and also led to the delayed fungal clearance and increased adverse event and should not be used as routinely in HIV-associated cryptococcal meningitis. Now, how specific guidelines? Because there is a very few trials for in the non-HIV patient cryptococcal meningitis. What the guidelines says that guideline says that 2024 induction of first 2 weeks, the preferred regimen high income strongly recommended in non-HIV patient liposomal amphotericin B with flucytosine regimen. In low income setting and HIV population, we can consider first regimen as a single dose liposomal amphotericin B. Also, we have to aggressively manage the raised intracranial pressure with therapeutic lumbar punctures and if necessary, repeated lumbar punctures. The consolidation is 8 weeks, fluconazole 400 to 800 milligram per day. 800 milligram preferred in the low income settings. Higher dose is preferred in low income setting because we are using single dose liposomal amphotericin B regimen. The maintenance is 200 milligram per day. And CD4 count, if CD4 count is more than 200, we can stop the fluconazole. If the CD4 count is less than 10, we have to continue consolidation therapy. What about the pregnancy population? The preferred drug is for the pregnancy liposomal amphotericin B or amphotericin B for induction and consolidation maintenance. Flucytosine is category C drug, fluconazole category D drugs. So we have to avoid that drugs. In pediatric population, there is no randomized trial for the pediatric population. The evidence is extrapolated from the adult population. Again, here regimen is same with fluconazole dose is 12 milligram per day, maximum dose is 800 milligram. So this is a conclusion. Then what is the preferred regimen? Looking at the evidence, the HIV-associated cryptococcal meningitis preferred regimen is in resource limited setting is single dose liposomal amphotericin B with flucytosine and fluconazole 14 days. The WHO has recommended this regimen for the HIV population. In non-HIV population, preferred regimen will be the liposomal amphotericin B 14 days with flucytosine for 14 days. If liposomal amphotericin is not available, what alternative regimen we can use? Then we can use the amphotericin B deoxycholate 1 milligram per kg per day with flucytosine 25 milligrams for 7 days, followed by the fluconazole 1200 for the 7 days. This is the ACTA regimen when there is a liposomal amphotericin B is not available. If the amphotericin B cannot be given due to the infusion reaction, what is the best regimen available that time? Then we can use for the flucytosine plus fluconazole. This oral regimen that is also recommended in WHO and from the evidence come from the ACTA trial. If the flucytosine is not available, what regimen we can use? Then we have to use the traditional regimen, that is amphotericin B deoxycholate with fluconazole for 14 days. Many of the region like our setting also flucytosine is not available, so we are using this regimen amphotericin B deoxycholate with fluconazole for 14 days. This is a historical standard care before the routine flucytosine availability. This is the take-home message from this slide, this presentation. Thank you.
Thank you very much, sir. Thank you for this excellent presentation, summarizing all the landmark trials and the global guidelines. It's a very vast topic, but you have managed to condense it very nicely. And from attendees, any questions?
I can put any questions or discussions in the chat box. So I had a question, like in the single dose amphotericin, though it was actually studied only in the HIV group, how can we extrapolate it to the non-HIV immunocompetent? Because in HIV, the challenges are quite different because most of them are either WHO clinical stage 3 or 4. And whatever we have seen in the HIV era also, the moment you start the amphoby, they start turning around and start showing improvement. And the CD4 also slowly builds up. And moment you reach crossover the CD4 of more than 200, you're also comfortable that it's working. But the issue happens if you start ART without diagnosing crypto, that is when they manifest as iris or unmasking OI. But that's not what we actually see in immunocompetent. In fact, immunocompetent, we see even if you start treatment, there is a phase where they become very sick and then, sort of improve after that. So, my question, I have two questions. One, the single dose, how effective is the evidence and what is the adverse event profile giving a massive single dose ampho, as opposed to can we extrapolate the same to immunocompetent hosts?
Yes, ma'am, because the guideline also recommended that the single dose is preferred only in the HIV setting. Guidelines still prefer regimen in the non-HIV, non-transplant or solid organ transplant. They prefer the liposomal 14 days regimen, not the single dose regimen, ma'am.
Okay.
Yeah, I think we don't have enough evidence for in non-HIV population, but considering the cost, availability, all those things, I think we have to wait for further evidence. Actually, this may be a good thing to explore further. Actually, considering the seriousness of the disease, and we have proof that in one population that it is non-inferior. So I think so. My question, sir, this um, screening for disseminated cryptococcus, what is the recommendation, sir? We had some patients who had bony lesions and associated lung lesions. I think CT chest is recommended, but what do you usually recommend as a screening test for disseminated cryptococcosis? Do you do a whole body scan, CT or PET scan, or?
Madam can answer that question. Not much.
So the catch here is, in fact, every cryptococcal antigen is the first test to come positive. Like we all know that the first starting point is always a cryptococcigenemia, following which you develop CNS disease. So in all patients, it's the first step is the cryptococcigenemia. So the blood is positive. So regarding disseminated, it's species as well as the immunity dependent. So the GATI is, I think, a couple of patients, Dr. Selva had also had, one was GATI, if I recollect.
Yes,
The
yes, ma'am.
GATI is much more told to have been more sicker, severe, as well as more prone to disseminated, and they take a longer time to clear also, is whatever I understand. So, like you said, again, bone lesions, are quite, uncommon. What we see commonly is lung, because the theory behind it is wherever there are fine capillaries, this filters out. So the two places where there are very fine capillaries, one is brain, choroid plexus, and other is the lung, where the alveolar capillaries, and so that is why it manifests predominantly as pulmonary and CNS involvement. And in HIV, they do see skin cryptococcomas, like in the skin itself, you see nodules, which when you biopsy have the fungal spores. So that is in a specific immunocompromised host. I think Dr. Baya is there in the panel. I think maybe Dr. Baya, you can say your comments if there's anything.
Uh, In the comment box, Dr. Baya has sent a single dose is used in other infection like leishmaniasis or others. So maybe applied in here also among immunocompetent. Yeah, that's a good thought. So, and then the one more common problem what we come across is vision decline associated with cryptococcal meningitis. So, for one patient, we have done optic nerve sheath fenestration also. There are some isolated case. Apart from doing CSF drainage intermittently, is there any evidence of optic nerve sheath fenestration? Last time when I searched, I could not find out good evidence for that. Considering that this is also intracranial pressure that is causing visual decline in these patients. So how to manage that more effectively? That is one more question.
Our guidelines says that if the refractory raising calibration, we can go for a ventricular run or shunting also, because main problem is obstruction. So that we
Correct.
have to relieve, because no other medication can relieve that obstruction. So mechanical way to remove the pressure is best strategy.
Yeah. And one more problem is here the ventricles are not dilated usually. So ventriculoperitoneal shunt may be very, surgeons also may be hesitant.
Yes.
So that is
So,
one more thing to
most
notice.
centers actually manage with a lumbar drain. In fact,
Lumbar drain.
in the HIV era also, that was what was preferred. So especially, taking up a seropositive patient to theater, those are the times where there were resources are limited and you don't want to contaminate the instruments and all that. So the easiest option is you do the opening pressure. Any opening pressure more than 40 or 45 is when they start actually trying repeated LPs. So moment it crosses the 55 threshold, if I recollect my medicine days also, they used to put off a lumbar drain and leave it for 3 days, so that you're avoiding recurrent pokes. So that was one thing. The problem with cryptococcus, like Dr. Selva rightly pointed out, is there is one group which will only cause a uniform raised ICP, and it just alleviates with relieving the pressure by doing a CSF. There's other group which behaves like TB, it causes basal exudates, trapped ventricles at multiple locations and the anterior also, and it causes adhesions. So this is the group where, the ventricles might be one is small, one is big, and you don't know where to insert the shunt. So those are the groups which are a bit tricky. And other important thing to remember also in an immunocompetent host is the PIAS, the post-infectious inflammatory response syndrome. So the moment you actually start the ampho-B is when the antigen destruction happens, your body reacts like how in TB you get the paradoxical worsening. So that also causes raised ICP, worsening lesions, worsening edema. So in fact, in that group, steroids are very, very helpful. Though the trials uniformly say steroids cannot be given, but there have been cases where we have salvaged by giving steroids in these type of in post-inflammatory response.
Yeah.
I'll just
Doctor,
like to add something.
yes,
Yeah.
ma'am. Mhm.
Yeah, so when we see a patient of chronic meningitis with vision loss, yes, definitely in cryptococcal, we always think of race ICP. That's where this optic nerve fenestration idea came to the doctor's mind. But we need to remember that these are all uveo-meningeal syndrome. So we need to confirm that there is it not any other associated, like some direct
Local
infection or
problem,
some
ophthalmological
cryptococoma,
infection.
or like some local cause that is not exactly due to race ISP. So I think there is one study where they have taken almost around 32 patient of severe vision loss, and when they analyze the etiology, yes, almost 50% was due to race ISP, which they targeted with, like Madam Angel has spoken about, VP and keeping the lumbar shunt drain for some duration of time, just like how they do the EVD, they calculate. So I think we need to keep in mind the other etiology of vision loss also. Let's not just think that it's only one particular etiology.
Thank you, ma'am. Thank you. It's a very valid point. And one more thing I want to discuss is some in the guidelines it was mentioned that we have to show culture negativity to end the induction phase at the end of. So how to make it more practical, because when to follow the cultures, when to send the culture.
So yeah, I think we can hear it, because whatever we used to do in the like in the HIV patients at least, was you send the first LPs for the confirmation. 48 to 72 hours is a response tap. So every time you do a tap, they will culture it. So not the therapeutic. So the response tap will be cultured. So then the third will be at the end of 2 weeks of induction. So that will be sent at the 10th day, 10th or 11th day. You send it so that by end of 14 days, you know whether the culture grows or not grows. So at 2 weeks, we expect the culture to convert. If it doesn't convert, then on a weekly basis, you need to do a tap and culture. So this is the most cost-effective way, because doing as per guidelines, you almost repeat it every day or alternate day. Then it's not cost effective, and its resource is also a problem. So I think day 0 is confirmation. 48 to 72 hours response tap also you need to culture, and at the end of 2 weeks of induction, so you time the culture in a way that at the 10th and 11th day, by that, so that you finish the 2 weeks and you have the culture report, and you can make a decision whether you want to continue or not. But the catch here again is the species. So species Gattii will usually take time to clear compared to neoformans. Neoformans better response than the Gattii. Dr. Baya, any comments from your side?
No, I would like to know your experience. Like for us, most of the time the culture does not come positive. So, there we have a lot of problems. So we follow the diagnosis based on cryptococcal, our antigen titer. Our fungal culture do not grow the cryptococcal. Very fewly it grow. So what is your, your findings or your experience in those patients whom at day 0 only you cannot find a positive culture? Do you do a titer again, or like in follow up
So
you usually follow the titer? So I don't know.
yeah, unfortunately, we don't have a quantitative
we don't
titer.
have quantitative,
Yeah, so
but
our
yeah. The last
Okay.
the cryptococcal Gattii patient we managed, the culture was initially positive, and at the end of second week also it turned out to be positive, and at third week culture only actually we got negative. So
converted.
ultimately we gave induction therapy 4 weeks. So immunocompetent patient with Cryptococcus Gattii. So that's why, because of the culture positivity, we had to extend. Like Dr. Angel told, I think 10 days in case of neoformans, I think it's good to do at 10 days, and then if it is negative 14 days, we can finish. I think that would be a practical point. But Gattii, again,
Takes
it is
longer.
invariably 4 weeks. That is what our experience is.
So the quantitative titers we don't do, ma'am. So ours is more of a LFA, lateral flow assay, which only says positive or negative. So other problem is your antigenemia. Like if you have titers, you can go by that, because your titers keep progressively reducing, but it never becomes negative. It takes a long time to actually test negative. So that
Yeah,
is the
true.
issue. Yeah. So
So,
we cannot continue induction based on the antigen presence,
titer.
positive,
Yeah,
negative.
yeah,
But at
yeah.
least a reduction in the titers are, because the culture, of course, you need an enriched media, and there are specifications for the fungal cultures. Here also, we do have challenges. India Inc., if you send a fresh sample at a particular, specifications, India Inc. comes positive. And most often, our cultures are quite, we have a very robust culture facility, so that it's enriched culture, which almost certainly, if the India Inc. is positive, 100% it grows. Sometimes it grows later also. In fact, we do send sometimes, and we do send blood also. Like in HIV, we've sent blood in specific fungal culture bottles, and we have gotten positive culture growths. So I think, yeah, that would be considering your center being a very high volume center. So developing the diagnostic capacity can also be, considered in the future, especially with
Yes,
regards
very,
to,
very true, very true.
yeah, because culture, you have the other culture facilities. It's easy to develop this one. So I think we can work on that.
Yeah, but we do realize that most of our patient, Indian ink doesn't come positive, culture doesn't come positive. We wait for the titer that we send to the private, that
Oh,
comes positive. So,
okay.
yeah, for us, that is a problem, like the
Yeah.
positivity rate. Yeah.
Sure. Definitely we can address that part, ma'am, because I think it's a technique which is the
Yes.
main thing. Yeah.
Mm.
Okay. So I think we had a very good discussion, and thanks to Dr. Mahendra Thakre. I think Sir like Dr. Selva rightly said, it's a very big topic, multiple things to discuss, but he summarized it very well, throwing light on some important trials and the evidence on cryptococcal meningitis. And Dr. Selva, any comments from your side? Anything?
Yeah, personally, I learned a lot actually. So extensive presentation and very crisp to the point. And thank you, sir. Thank you, ma'am, for this opportunity.
Thank you, Dr. Baya, for pitching in, and thank you,
Thank
team.
you. Thank you.
Thank you, team at Negrims. I think this month the webinar and the journal club was fantastic discussion on cryptococcal meningitis. So, for the audience, if you missed any part, you can watch it in the YouTube Climb India YouTube channel, and kindly participate in the upcoming webinar, which will be hosted by AIMS Bhubaneswar. This will be on neuromyelioidosis and viral encephalitis. They'll be discussing their experience on these two diseases. So thank you all. I would like to thank all the panelists and Dr. Selva for spending his time with us and sharing his expert inputs. Thank you, everyone. See you in the next webinar.
Thank you.
Thank you.